One thing really exciting in the health information exchange world is as we continue to build infrastructure, really looking at how do we support not just in that sort of classic emergency point of care, unexpected visit, but how do we look really across a person's whole health, both their physical needs, their social health needs, health-related social needs, and provide infrastructure to help that care coordination, make sure that they have services that will help improve their health, even if that's not the classic clinical support.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. The purpose of this podcast is to tell the stories of Alaskans of interest and importance. Today, our guest is Kendra Sticka, the Executive Director of healthEconnect Alaska, which is the state-designated health information exchange. Dr. Sticka holds master's degrees in nutrition and adult education and a PhD in biochemistry and molecular biology. The ability for healthcare information to be shared among healthcare organizations has the potential to lower healthcare costs and improve outcomes. The siloing of healthcare information, which is the current common practice, leads to unnecessary repeated lab tests and imaging. Sometimes the inability for a provider to access a patient's medical record can lead to life-threatening delays or mistakes in care. The availability of a shared electronic medical record for the state is a potential game changer, but it requires maximum buy-in. Today's episode seeks to achieve that buy-in by answering basic questions and responding to concerns about the security of protected health information. Some vocabulary. You will hear us use the acronym EMR. This stands for Electronic Medical Record, and it is used interchangeably with EHR, which stands for Electronic Health Record.
Kendra Sticka, welcome to the podcast.
Thank you. Thanks for having me. I appreciate being here.
Where did you grow up?
I was born and raised in Anchorage, so I lived my whole life here until I moved away to go to college after high school, decided to go somewhere else for a bit.
Where'd you graduate from high school?
Service.
Service?
I did.
So you grew up in that part of town?
I did. Yep. My parents moved here from Nebraska in the 60s and bought a little house in the Rabbit Creek area. So I grew up in that part of town, and my mom still lives there.
And you're a registered dietitian?
I am.
How did that happen?
I took a class in high school that kind of piqued my interest in nutrition. I decided to major that in college, and I was one of the only people I knew who finished the major they started with. Yeah, just really fascinated in nutrition, both the sort of physical aspect of it, as well as just all of the social emotional pieces that go along with food and nutrition. And so it was an interesting career field, took me in a lot of different directions.
You were the first dietitian to be on the podcast.
Oh.
So we've never really explored what a dietitian is. What do you do? What does that job look like?
Yeah, that's a great question. So one thing that was really fun for me about being a dietitian is there's so many different directions you can go. There's three broad areas that people typically work in dietetics. Either there's clinical nutrition, which is really what we think of as therapeutic nutrition, inpatient, outpatient hospital, really helping people with their personal health care and nutrition. There's public health nutrition that really looks at nutrition from a very broad-based public health perspective, how we have systems that promote good health through food and nutrition. And then there's an arm that's really more food service, food management, that sort of aspect of nutrition. So across those fields, I primarily worked in more of the clinical nutrition area and then some public health. So that was where I did most of my career, but really a lot of breadth in terms of nutrition obviously touches a lot of aspects of lives.
Did you work in a hospital?
I did. I worked at Alaska Regional Hospital, both inpatient and outpatient there. And then I moved into doing kind of contract work where I worked a little bit at a lot of places. So I worked at API, I did some drug and alcohol treatment centers, I worked in long-term care, I worked at the VA outpatient there. And so just a lot of different settings, which again, I just found to be really a fun way to practice. It let me see a lot of different people in different situations.
Are you required to do continuing education to maintain your license? Are you licensed?
Yep. So there's registered dietitian as a national credential. So you have continuing education requirements to maintain your registered dietitian nutritionist at the national level. And then there's state licensing as well.
I brought that up because in the 80s and 90s, speaking of cardiovascular health, we did this whole don't eat any fat, but then we replaced it all with sugar. And we had these sort of high sugar, non-fat type that ultimately were not really improving people's cardiovascular health. Yeah. So I assume that what a dietitian was saying in the 90s might be very different than what a dietitian is saying today.
Absolutely. I think it's one of the fun and frustrating areas of practicing nutrition is that it's constantly changing. And I think it's so many things in healthcare. We provide information and treatment based on the best information we have at the time and what we know, but that continually changes. I went to college in the 90s, so it was my undergraduate was at that time. It was very much the low fat and that sort of thing. And then as more information came out, it's wait a second, there's trade-offs here and it's not necessarily a good one. So I think it is such a critical thing that we all learn, and that continuing education becomes so important to have the best information for what we know at the time and make those decisions. And of course, different for different people as well.
Do you feel pressure when you're eating in public to model good behavior?
That's funny. I used to. I don't anymore. I used to feel like you'd go through the grocery store and you see someone you know, and are they looking in your cart? And I think I've gotten to a place that not so much pressure there, but it's certainly, I think early in my career in particular, it felt very much, well, people are going to be watching everything I'm doing, or if you're asked to bring food somewhere.
And I imagine, I'm just in my head thinking about like a convention of dietitians, that there might be a lot of judgmental looks from one plate to another as to what people are choosing to eat or not eat.
My first very large conference of dietitians was an interesting experience. I will say that. But I think more and more too, dietitians have really gotten away from that stereotype. We all eat different ways. We all have different things we do, but there's definitely a stereotype.
Not speaking for all dietitians, but just speaking personally, What do you see as the biggest challenges regarding diet in our culture today?
That's a good question. And I feel like for a number of years, I've been out of really practicing as a dietitian. So I get out of that world, but we've gotten so far away from just normal, natural, real foods. And I think early in my career in the 90s that everything was fake and processed in an effort to make it quote unquote healthy, really, I think took us down a rough, not a very good road. And I think the movement towards just foods closer to how they came to this earth.
Shopping on the edges of the grocery store rather than the middle of the grocery store.
Exactly.
The produce and...
Yeah, and the less we process it. I used to, when I taught classes, talk about apples. They grow on a tree. You process them a little bit. You get applesauce. You process them some more. You get apple pie. We need to get, back closer to the tree in terms of how we eat things. And sometimes I think, too, just overemphasis on food as being everything, having it keep a place in life, but a balanced place.
Let's talk about what you do now. Yeah. Because, as you said, you've moved away from the dietitian world. Mm-hmm. Dietetics, is that what the word is? Yeah. You've moved away from dietetics. Tell us, what's your current position?
Yeah, so I'm currently the executive director at healthEconnect Alaska, which is the health information exchange for the state of Alaska. I've been in this position just over a year, so this is a really new area for me. It was a pretty big career shift. I was at UAA as a faculty and then administrator for about the last 14 years full-time prior to coming to healthEconnect. So I was teaching nutrition and then administrator in the College of Health, and then toyed with the idea of something different. And this came up, and I took some of the things that I really enjoy professionally in terms of healthcare, looking at the health of Alaskans, doing collaborative and connected work. And so it just seemed like a good fit, but definitely a different role.
What is health information exchange?
So really, at its essence, health information exchange is simply a technology platform that allows safe and secure exchanging of health information that currently lives in different electronic systems. So when there's an electronic system at one healthcare facility and another healthcare facility, the health information exchange allows sharing that information while retaining all of the protections and privacy that need to be retained with it.
And the health information exchange that we have in Alaska is healthEconnect.
Correct.
Can you tell us a little bit about healthEconnect and how it's currently being used?
Yeah. The health information exchanges across the country really came up as electronic health records became a thing in the Affordable Care Act.
Because the Affordable Care Act required it.
Exactly. And that transitioning to more electronic health information and exchange of that and making it available.
Practices that were still using paper charts had to select an EMR and move towards an EMR or something like that.
To some extent, yeah. And not 100% true, but generally, yeah. And so then there was really this question of how does that information get connected? And I think really it's, at the end of the day, it's always about the individual person who it's their health and how is that the best systems to promote their health. So really an evolution in where healthEconnect is right now. I think really at a great place. We're part of and this is relatively new in the last several years, part of us, I think of it as a consortium of states that share the same technology infrastructure, but we each have our own local governance and really how we deploy that in the states. So healthEconnect is the local governance. We're a nonprofit entity, so we're not a state agency. We're a nonprofit entity. And we use this technology platform and work as part of that consortium to really modify the technology to meet the needs of Alaska, which I think strikes a really nice balance for a state like Alaska that has low population, so low volume, but you still want that robust technology and sort of a best in class, so to speak, of technology infrastructure.
I am a physician assistant, and I was at the VA for 5 years prior to running for office, and now I'm at a independent urgent care. We have our own EMR, and it's our urgent care. So people come there on a Friday evening because their doctor office is closed. I can't see any of those records. I don't know who has eyes on the healthEconnect system and what can be viewed there, because from my limited experience, it's never been a part of my world, and it's currently not a part of my world.
No, it's a great question. And I think you bring up probably the perfect scenario of where the health information exchange can have so much value. And I think we're really at a place in Alaska of saying, how do we get more utilization? Because it is such a valuable resource. So essentially a couple of pieces. So speaking to your situation, there's really, I think, two parts to the health information exchange. Obviously, data has to come in to make it valuable, to create that infrastructure. And then data has to go out. It has to be used somewhere to actually create that value in treating a patient or coordinating that patient's care. And right now, there's been a lot of emphasis on how do we get a robust enough data source that makes it valuable for someone to look there. I think we're still growing that, but I think we're at a place that there is a good data set there that helps providers make those decisions. So then in terms of accessing that data, there's really two primary mechanisms. We have a web-based portal, and then some EMRs will allow it to be a single sign-on in their EMR, where when you go in the EMR, you're already signed in, you just click on the Health Information Exchange tab and it's there. Now, I also want to be really clear, either of those access are still only if you have a care relationship with that patient. HIPAA and all of those standards, of course, still apply. So even our web-based portal has really strict security standards and account provisioning and things like that. So just to be clear, it's not just out there for anybody. So in your situation in an urgent care clinic, it may or may not be that your system would allow that single sign-on, but even absent that, if you went through all the provisioning process and your license and all of that, so you have a provider relationship, you'd be able to access those records that are in there for that patient. So if they come to you on a Friday night and you want to see, gosh, what has happened to them? What are their conditions? What are their allergies? What are medications they're on? Because all they can tell you is I take 3 pills in the morning and 2 at night. And so that you could see those things. So that would be in the Health Information Exchange if it was contributed by whoever prescribed that to them.
And am I an outlier in being a provider in Alaska who's not using that?
I would say no. And I think that is probably at this point, as I've again been in this position about a year and really working with where the organization is in our growth and where really health information exchange utility is being used in Alaska. I think, again, you have to have enough data there for providers to say, hey, this is worth it to log in and see it. And I think we're beginning to get to that critical mass. I'm not saying we're 100% there. We still have to continue to provide that. It becomes a little bit of a chicken and egg situation. People get in and see there's value, and then they're more willing to contribute data. So continuing to work on that. But I would not say you're an outlier. And I think that's where we're continuing to work on looking at how that looks in people's workflows, providers' workflows, to make it as easy as possible to access that information. Of course, doing account provisioning that allows you to see what you're supposed to see and not anything you're not supposed to see. That's always the top importance.
I will share my experience using CPRS, which is the EMR of the VA. I know that if I, as a provider, access someone's chart that I have no reason to access, that I could be fired for that. And that's part of our yearly ethics training, is that if a governor's child, for example, was getting care at the VA, you can't access that governor's child just to see why they were hospitalized. You saw it in the news and you want to go see. You cannot do that. You will be fired, and people have been fired for that. I say that because I want people to understand that it's not just a free-for-all, that there's all this data that anyone can go access. If you access something without permission, without a good reason, there are severe consequences.
I think any of us who worked in healthcare, it's the same situation. You could access more information than you are supposed to. And if you do, people are watching and you will get in trouble. And so that is very much the same situation with the HIE. So our data, and I think it's really important that people understand, because we're a nonprofit and we're not a healthcare organization, it can feel different, but it's not. All those same rules apply. So everything in our database is really panel based. So if you want access, you will submit who's on your patient panel. And if there is a way, for example, if someone comes in, they're not a patient, they're in an emergency situation, that you can access the record, but there are specific screens that you attest to why you are accessing it. And that's all auditable. It's all audited. And so exactly like you said, anyone in healthcare knows that is not a light thing to do, and it can cost you your job. So that's really important.
And Epic, I think it's like breaking the glass.
Yeah. And that term break the glass, I've learned, is used in different ways in different places, but that's essentially what it is at. And we have a different terminology with it, but it's that same concept that you're going through, and it's very clear. You're not going to accidentally land there. You specifically attest to why you're going in and what you're doing. And that would be unusual, and that's why it's auditable. So I think that part is really important. As you're a provider in an urgent care clinic, you get what you need for that particular role, not all the things.
But then when you mentioned earlier about having a panel, obviously an urgent care or an emergency room doesn't have panels of patients. You're seeing whomever walks through the door. They're not on your pre-list. You don't know they're coming there.
Yep.
So
And in that case, you would do that kind of break the glass where you would be able to access it, but you would have to clearly attest to why you were accessing it.
Because I'm providing patient care to this patient right now in real time.
Exactly. New patient in the door. And again, because it's all auditable, if you were saying that and that couldn't be verified, that would be a problem. But I think that's where it's one of the really powerful uses of something like an HIE is when someone comes in an unexpected emergency situation or just unexpected situation and getting records from different places. Even if it's the middle of a Tuesday afternoon, we know how hard it is to get records.
A very common occurrence working at the VA in primary care is when someone went to the emergency department over the weekend, was admitted to the hospital, could be Alaska Regional, could be Providence, could have been Matsu Regional, and had surgery, and that I'm seeing them for a surgical follow-up a week or two later, and I don't have those records. There's no clearer example where I need to see those notes. If it involved us calling medical records at that hospital, that just may not happen in the 30 minutes before the patient arrives. We have no way to get those notes. So then the patient is there, and you're like, what surgery did you have? Were there any complications? What did the surgeon tell you? And it's just all based on what they remember. And sometimes they remember a lot and sometimes they don't.
Yeah. I think that's a prime example. And that's exactly where the health information exchange that you could log in, even if you didn't have the benefit of having an EMR that it was fully integrated, it's a lot faster to log in there to a system and to be able to pull those notes for that patient that you're about to see. And that's where even efficiency of care, cost of care, the time that is spent tracking down records and getting faxes, for crying out loud, it's crazy when that information could be right there. And I think we're getting to a much better place. There's different types of data that healthcare organizations can send into the health information exchange. Some of it's very basic and some of it's pretty great, like the full dictated discharge notes. That would be perfect when someone is coming in. And we have some places that send those in very nicely. And so it really helps streamline care, make care more efficient, decrease that administrative burden of tracking down records everywhere. And for the patient, then they can actually get what they need in that visit rather than you not really being able to help them because you don't know what the appropriate follow-up is, or you're guessing or flying a little bit blind, which also has its risk, of course.
Are there certain EMRs that work better with healthEconnect than others?
There are, and this is where I sometimes get into dangerous zone. I can't always remember all the ones that really connect well, but the big ones, Cerner and Epic, and there's a number of big ones, Meditech, that integrate really nicely and do single sign-on really nicely. Some don't do as nicely. So that's where we just work with organizations when they're connecting to figure out what's going to be the best path. Always, the closer we can get it to right within a provider's workflow, that's always going to be better because you don't need more clicks and more logons. So we do everything we can to get it as easy and clear as possible. There are some great tools, though, that can't necessarily be embedded in the EMR. That's more like population management. So you can look across your patient panel. So if you work in a setting that you know these are the 100 or 200 or 1,000 patients that are in my clinic or whatever it is, that you can look across them and filter by different things. What are my patients who have this kind of condition, or do I get alerts when they've been discharged from the hospital or were admitted to the hospital? How often do primary care practices have no idea that their patients even went to the hospital? So they can get notifications on that so they can make sure to follow up appropriately, check in, and help people get that coordinated care much more efficiently. So there's some nice systems for managing a practice's group of patients when we know patients move around settings. They go to specialists, you may get a referral somewhere, you may just choose to go somewhere. So the more that data is all in one place, the more primary care can really help support that patient across their care continuum.
Are you able to give a number for like how many patients are currently in healthEconnect?
That number is available. I cannot tell you off the top of my head. I wish I could. Yeah, how many like patient lives are represented in?
And the reason why is because I think as somebody who doesn't use it, if that number was like 60,000, I might be like, then that means that probably a lot of my patients aren't there.
Yeah. Actually, interestingly, the number is larger than the population of the state of Alaska, which when I first saw that, I was like, that's got to be wrong. But the reason being that we have visitors that come in and get care here. So if they get care here, it's in there.
And so if we have 2 million tourists and they go to a place that uses healthEconnect, then their record from that visit would be there.
Exactly. Because it comes from the facility. So it's a pretty large number of patients.
Well,
there's
it's
a pretty
larger
good
than 760,000, for example.
Yeah, I think, and that's only, like I said, because when it came up, I'm like, what? This doesn't make any sense. And it's, oh, okay, I see. I think the issue then also becomes how much data is on that person you're looking at. Again, I think I'm certainly not saying we're there as far as all the things, but I think we've made a lot of progress to where there is enough there that does make it a really valuable resource. And I also think the more we start using it, the more it makes sense for places to send more robust data.
And I guess in that example that I gave, if my patient had surgery, and I'm seeing in the urgent care, and they said that they had surgery a week ago.
Yeah.
Would that be something that would be available on healthEconnect?
Yeah. So it's pretty close to, because the data connections are made directly with the EMR. So it doesn't rely on someone sending a record.
It's either there or it's not.
Yeah. So it's very close to real time for those types of records, because it's all based on their EMR. And even when things are charted and a note submitted, and as a provider, there's timeframes that you need to get that done in. So it's very timely.
That's great. As someone who's used Epic, used Cerner, used CPRS, used Genesis, used a different emergency department EMR in California, using a current urgent care EMR here, having been on tons of different EMRs. I know that they're all different. They all require treating. They all require this frustrating period of not knowing how to do what you want to do. And I wonder, is there the same sort of issue if a new provider wants to access healthEconnect?
I would love to say no, but I think that would probably be not entirely true. So it's like any other system. There is a little bit of getting used to it. But usually once we show it to someone, it looks very much like EMRs look. Now, there are some nuances. This is where you're going to find this sort of thing. So there is a piece of learning curve. And I think that's a challenge. And that's where the more we can get things closer to right in the workflow. So really always working towards that. But I would say it's a pretty intuitive system in terms of how EMRs go. But just like you said, people don't usually want to learn the one they have to, let alone another one.
Right.
But I think that's also where we really have to help get over the hump that we're usually willing to learn something when we know the value on the other side is worth it.
An epiphany for me at your Health Information Exchange Summit that I attended last month. Was I was obviously seeing it through my own lens as a provider who treats patients, and how could this benefit me as a provider treating patients? Right. But what I heard a lot at that conference was looking at it more from a public health aspect and getting de-identified information that's being viewed as a compilation. We have this much diabetes in Alaska. We have these particular issues in Alaska, by looking at all of the data and compiling it and analyzing it in that way. And I hadn't really thought about it in that way as being a real benefit to the state.
Yeah, and it's interesting. So the Health Information Exchange is written into statute in terms of what people can do with data that's in the Health Information Exchange. And the state use and the public health use is interesting. Really, the primary allowable uses for the Health Information Exchange data are treatment. So exactly what you talked about, that point of care. Someone comes in, you want the data to treat the person. Care coordination. So people who have a known care relationship with that patient can coordinate their care, make sure they're getting where they need. And then related to billing and payments, health insurer could see that information however they got it. So it's really not new information or different that they're getting, but it's just a mechanism to get it. And then the public health use is really related to situations that the state of Alaska has a reason to have access to that data anyway. For example, there are reportable conditions. There are registries for certain diseases like birth defects and cancer, things like that, that they would have a legal allowable reason for the Department of Health to have that data. They could access it through the Health Information Exchange. They could also look across our data set related to those specific situations, but what they aren't allowed to do in our statute is us to give them anything they want in any sort of format out of the Health Information Exchange. So they couldn't go in and use it for just broad surveillance at this point, the way the statute is written.
Do you think that's a good thing?
I think it's an interesting conversation. The whole basis of a functioning Health Information Exchange is really based on trust and people being comfortable with how their data is being used. And again, I just always come back to that's someone's individual personal health information. And I think there are probably some things that make sense in a de-identified way. So again, very aggregated data across what's in there to look at and say, okay, in our state, what kinds of issues do we have that public health systems could help improve? But it's a delicate conversation because we don't ever want to get to a point that people or organizations feel that their data is being used in a way that stretches that. And that's a little bit of a judgment call, quite frankly. I think there's probably room for a little bit more broad use, but I think we have to walk down that road super carefully.
At the conference, there was a representative from the Alaska Native Tribal Healthcare Consortium who spoke about Alaska Native health information being used for reasons that had not been explicitly stated up front.
Exactly.
That they felt betrayed and were rightfully distrustful of sharing that information. That was also the part where I was sitting there being like, oh, they're talking about large amounts of healthcare data.
Right.
And again, from my seat as a provider, I just want to know what this person's medications are. Right. What did they take today? If they can't tell me, which many patients can't.
Exactly. And I think the great thing, and this is where I think health information exchanges have evolved as technology has become so much more robust in terms of being able to have more nuanced controls. It's not if you put data in, we open the floodgates, anyone who taps into that data set gets all of it. There's so many things we can do with data to tag it in certain ways or have certain filters or those kinds of things. And so I think it provides an opportunity in things like a health information exchange to have a really robust data repository, but it doesn't mean all of that goes out to everybody all the time.
I also want to talk about some of the really good things that can be done when you have more access, it sounds like, than what healthEconnect is providing in Alaska. The VA's healthcare system has an enormous amount of data, and there have been many studies done through using the VA system because they can have 400,000 patients participating, whether the patients know it or not. And an example would be statins, which is a class of drugs used to lower people's cholesterol to prevent heart attacks. We were taught in decades past that when somebody reached an age, whether it be 75 or 80, that it was no longer beneficial to stay on that particular medication. What we learned from a study using the VA data, where they could say that this many 100,000 veterans stayed on a statin in their 80s, and these other 100,000 people did not, is the ones who stayed on the statin lived longer. And it changed our practice. We now do not stop someone's statin simply because of their age. We have good data to support staying on this medication till you're 90, because we know that folks who stay on this medication live longer. And we know that from having access to a database that has hundreds of thousands of patients' records in there.
Yeah. I came to healthEconnect from the university. So you're always thinking about access to really good data sets. And I thought, wow. And at that time, I really wasn't familiar with the Health Information Exchange. That I had a different piece that I brought to the picture, but that wasn't it. And so I thought, wow, this is an amazing data set. And just like you said, when you think about health standards of practice and things that are formed based on looking across lots and lots of people and what works. Right now, data in the Health Information Exchange research is expressly prohibited. So essentially, if you get to the point that you would have to ask for IRB approval to do something, that's a no-go. Whether that's good or bad, I think there's some very good reasons, and we can look at some of the historical problems in Alaska of data use across various populations that we want to tread in that water very carefully. On the other hand, I think it's worth a conversation as far as whether it's research or something else. I just think it's worth thinking about pros and cons and having really good dialogues and what are unintended consequences. Where are the right limits on that? Because some really good clinical practice can come out of understanding large populations.
You're a nonprofit.
Yeah.
Do all states do it that way, or is that an Alaska way? And if so, why do we do it that way?
Yeah, that's a great question. So not all states do it that way. Many do. Some states have multiple health information exchanges. Some states have essentially that functionality in their Department of Health or their state department, have a department that does it. It's either a nonprofit or it's embedded somehow in a government system. Actually, I just recently had a conversation with Bill Hogan, who was the commissioner when the Health Information Exchange came to be, and he was also a dean at UA when I was there. And he was talking about when they were setting it up as a nonprofit, how they really talked about the importance of that because it's not part of the state government, because you don't want it to be controlled by state government because of the issues with data sharing and data use for different purposes. You also don't want it to be in a given healthcare organization because that brings with it its own issues. So having that independent nonprofit, I think really lets us stay in that place that we're a public good. We're here for the public and for Alaskans. And I think that's really, anytime conversations happen, try to come back to what does it mean for an individual Alaskan and their health?
I can appreciate that. I can also see how, in a way, it, as somebody who really didn't know much about it, would be like, who is this random nonprofit? And so in a way, that's almost like the state's doing it. You understand the state was mandated to do this, or the state wanted to do this, and the state is providing this service. And so you don't ask as many questions. And you're like, who is healthEconnect?
Right. Yeah. So that's a great question. I think it's a really, really good point. And I think education around that. We are a nonprofit. We are not a state government, but it's interesting because what we do as the state designated health information exchange is dictated by statute. And our board seats are even dictated by statute. So who's on our board? So for example, the commissioner has a seat that she can designate. So her chief health data officer is currently on our board as her designee. Dr. Zink was previously on our board. So each seat is designated in statute. So we have representatives from various aspects of healthcare. So it's an interesting dynamic because it's not a state entity. It is a nonprofit, but by being designated as the state HIE, then we're bound by the statute and regulations that accompany it.
And it means that another nonprofit can come up here and try to do the same thing. Like you are
exactly.
So we have information exchange for the state of Alaska.
Exactly. So we have a contract with the state of Alaska. They put out an RFP. So a couple of years ago, so we responded to that RFP and were awarded that. As far as a state designated health information exchange, we're it.
If someone is listening and they own a clinic or they work with an organization that's not currently part of healthEconnect, what's the process towards becoming connected?
Yeah, that's a great question. Our website, of course, has contact information.
What's your website?
healthEconnect.ak.org. So usually then we'll start with just a conversation to see what they need, what they'd like to do, how they want to connect, what EMR they're on, what kind of technology they have access to, and then decide the path forward. So everyone has to sign a participation agreement, a business associate agreement that then lays out those requirements, how things can be used, how they can't be used. And that's really all from a HIPAA standpoint for people in the healthcare world. It's generally a covered entity under HIPAA that then contracts with us so that all those laws and rules carry through. Once we have that agreement in place, then it's really a matter of determining what their capabilities are for sending data in, for accessing data, and then we just work individually. It's flexible. Different places can send and receive data in different ways.
I'll just offer, I think folks who don't work in healthcare often think that there's more problems with HIPAA in terms of private information getting leaked out.
Right.
From my perspective, working in healthcare, I think it's the other way around. And I feel like sometimes people don't understand HIPAA properly and actually put up unnecessary roadblocks. And an example that I would use that happened in the emergency department more than once is we have an unconscious patient brought in by ambulance. We know that they are treated by a psychiatrist, and we call the psychiatrist's office because we want the most recent note, or very least the most recent medication list, to potentially know what this person may have overdosed on. And the person answering the call says, "Do you have a signed release of information?" And we're like, "No, the patient is unconscious."
Right.
And they're like, then we can't send it. And I'm like, no, you don't understand HIPAA.
Yeah.
And that person is just insistent. I'm so sorry. If without that signed document, I cannot send you, the emergency department, their medication list. And I feel like that's something that I think the public doesn't understand, is where the goal is not to prevent healthcare providers from having access to life-saving information.
Yeah, absolutely. I think you're spot on. And I think there's a lot of, just understanding and education around that, and that security of how information is protected so it doesn't go out where it isn't supposed to. I mean, data security is scary these days. There's no question about that. But it's such a huge emphasis in anywhere who's dealing with health data in terms of the security measures put in place. And I think you're absolutely right in terms of people understanding what HIPAA means and what it doesn't mean. And I think we would all want that to be available if we end up in a situation that we're not able to respond for something, that there's enough information to take care of us safely.
Are there any things that I didn't ask or cover that you think would be important to share?
I guess the one thing that we're talking a lot about with health information exchange that I think is a newer area, and I think it's exciting as healthcare really looks more broadly at whole person health and social determinants of health, and even how we use things like the Medicaid 1115 waiver for health-related social needs, food as medicine, things like that.
Housing, even.
Housing, exactly. And of course, the food as medicine as a dietitian, I'm like, finally, we're here. That there's really this recognition. So I think one thing really exciting in the health information exchange world is as we continue to build infrastructure, really looking at how do we support, not just in that sort of classic emergency point of care, unexpected visit, but how do we look really across a person's whole health, both their physical needs, their social health needs, health-related social needs, and provide infrastructure to help that care coordination, make sure that they have services that will help improve their health, even if that's not the classic clinical support. And we've been working with the state on how we start to build up infrastructure so as there are more opportunities for things like Medicaid waivers for housing supports or food or things like that for a health-related social need, that we can be a backbone of technology to help get the information where it needs to be so people can get paid for those services.
I think a lot of patients are eligible things that they don't know they're eligible for. And
yes,
I would say that I have a little bit of awareness beyond what a typical medical provider does because I'm in the legislature.
Right.
But perhaps the urgent care provider doesn't know to tell the patient, hey, did you know that you're eligible for SNAP?
Yeah. Yeah.
And we can print off your application or something along those lines. Hey, part of the reason why your diabetes is so out of control is because you're eating boxes of Oreos because they're on sale. I don't know. Whatever it is.
Exactly. And I think the more we can build, and this was the thing that I get excited about with the Health Information Exchange, and I think Commissioner Hedberg and her team have just been really great about thinking, how do we integrate systems? So as these things come out, we have one place that providers and care managers, whoever those people may be, can see that whole look at a person and what might help them be healthier, what might help lower their healthcare costs, because typically healthier people also don't have as many healthcare costs. And so how do we have systems and technology systems that we can see a bigger picture all in one place, and then make sure people know where they are eligible for something that might really help them and offer it up. And whether they want that or not, that's okay, but at least they know that's an opportunity. So one thing I'm really excited about, I think the traditional health information exchange that we talked a lot about in that point of care, super important. And I think that will always be a backbone. But there's this whole other realm of care coordination and looking at health-related social needs, that there's so much opportunity there. And we know that so much of health is dictated by those other non-clinical factors that we really have an opportunity to impact health.
Well, Kendra Sticka, thank you so much for being on the podcast today.
Thank you for having me. I really appreciate it.
Thank you, listeners. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@akleg.gov or call my office at 907-269-0123.